thank you. This has been fun. I did get here last night. I flew United and didn't get yanked, so it's good to be here.
Well, you're not Asian.
That's right. So here's a see you Buffaloes. So no financial conflicts. So let's talk about some of where we're at, where we're going. So thank you for this technology that really has transformed the treatment of people with valvular heart disease, but there are further areas for improvement. And we see here access sites shifting over really just 4 years, so dramatic and really technology driven. If you recall first generation, the number of people who could have transfemoral approaches is maybe 50%. And now in the US TVT registry, 93% have transfemoral, 7% have alternative access. So that's technology driven. But here's perhaps where we need more technology help. Not much change in reducing stroke rate. And do we need cerebral protection? Obviously, still an open question, but something in the next 5 years, hopefully we'll get more data on. And here, two of my favorite patients, husband, wife, TAVR. One got a Sapien 3, one got an Evolut, and they talk about it as the moo and the oink between the two of them. But we do need more choices. There are some further lowering costs. It's as well pointed out by Jeff. This is very, very expensive technology, and we need improvements in technology because this still happens. These are two of the major complications we had to deal with in the last month. One, annular rupture that was not predictable by any pre-procedure CT sizing. Unfortunately, despite the development of hemopericardium, it stopped and the person left the hospital, which is rare. And this, so this is the balloon fragments that trying to pull it out got stuck in the external iliac. And between doing a cut down and also pushing it out from contralateral side, coming up and over. But you know what this is? This is a endarterectomy. This is a piece that came out of the external iliac. So, balloon ruptures and to do a rather than a longitudinal rupture, but that's terrible because it then goes like this when you're pulling it back.
You showed a case of that in a workshop yesterday, actually, of how to get that out if that happens.
Good, I should have been here.
It's only a 4-hour thing.
Yeah, well, it's about what we took.
Yeah.
And so, one of the issues, growth, will we continue to see it? Expanding indications, will it continue? What are the drivers? So I'll break it down to the two tsunamis. Wave one is the surge from expanding indications, inoperable, high risk, intermediate risk, valve-in-valve, maybe low risk. We'll see. Wave two is a surge that's going to be based on demographics, as we'll see. I don't have the latest data cut because everyone just submitted their data, but it's clearly over 35,000 TAVRs performed, TAVIs performed in the US in 2016, which surpasses the number of isolated surgical AVRs in the United States. Isolated surgical AVRs, not AVRs with other. But that's a notable historical event. But despite the broad vertical axis, look at the raw numbers. Mean age has gone from 82 to 81. Why is that? Will that change? There's no really major age creep so far. And to me, this is the take-home lesson. This was a study from Helsinki that was done was quite some time ago, but it was very good because it was population-based. It wasn't a referral bias. It was just kind of open the telephone book in Helsinki and call up people and do echoes on them. And it just shows this age-related degenerative aortic stenosis, which is the predominant form of AS, and with a huge number of people, therefore, in the older age groups developing severe AS. So many of you may recognize this, and you may ask, what's Carroll doing? Why is this in a talk on TAVI? Eric, why does this talk contain this slide? Because it's the key to this. When these people came home from the war, it was time to boost the population. And both in Canada and the US, we had 18 years of a lot of extracurricular activities resulted in a fertility rate that produced a large population surge at that point that now is playing out. How's it playing out? So this is a population pyramid. And so if you look here, in 1960, the US patient population, so you see 5-year increments of population going from the newbies to the elderly, males and females on this. And this is, when our parents came home from World War II, what happened? The baby boom. In 1990, we had moved up to this. In 2020, we're entering the age of degenerative aortic stenosis. This is Canada. Same thing happened in terms of this boom, baby boom. And so be prepared. This is the aging of the population. Unlike Italy and Japan, where down, if you go to the bottom of the population pyramid, it's very narrow because they're not producing many kids. We still have countries where we, due to immigration and also a reasonable birth rate, we're not seeing this lack, but we have baby boomers now moving into aortic stenosis. Next topic, refining patient selection for all 3 treatment modalities. We really have 3 because there are some people who never come to us as cardiologists who are deemed appropriately of not being appropriate for anything but palliative treatment. But there are kind of 2 major choices that are emerging that we have to better understand and do a better job of helping our patients make decisions: TAVR versus palliative, TAVR versus SAVR. And that's important to keep in mind when we're talking about treatment, that we have in treating 80-year-olds, and these are all comers, 8.7 years of life on average left. Many of the patients we see with comorbid factors, it's less. And so here's the quiz. What's this still from? What movie? Who's the director? If I win this game of chess against you, Death, will you allow me to live? Seventh Seal, Ingmar Bergman, 1957. Why is that? So he had just returned from the Crusades, and he played on the beach in Sweden, Death, a chess game. If he won, he'd live longer. If he lost. So yes, I will give you a new aortic valve, but I will be back in 3 years to take you. And by the way, the valve costs $30,000 plus other costs, and you may not pay it, but your children will pay it because of the huge healthcare costs that are associated with that. So, as pointed out by the 2 excellent speakers addressing the low risk, yes, TAVR increases survivability at 1 year, but it's still an elderly patient population where life is limited. It's not the fountain of youth, and we have to keep that in mind. So, outcomes, increasing survival is important, but increasing functional state, independence, quality of life are also very important. How to measure this? So, this has turned out to be really, I think, an important development using a standardized questionnaire. I said, well, we talk to patients about these things, ask them how they're doing, what their limitation, but it's standardized and it's given to the patients, they answer it, and you get very interesting feedback. Sometimes I walk in the room and I take a look at that, and boy, that's a different impression of how impactful this treatment has been, if it's pre-post, or just how miserable you are pre. And it really assesses more than quality of life. It's really functional state. And a scale of 0 to 100, and many of these patients come in and they're below 50 and sometimes even worse. And then you ask yourself, what is making you miserable? Is it your aortic stenosis? That's something we might be able to change. But if it's your chronic neuropathy, if it's your chronic low back pain, if it's your severe COPD, guess what? We're not going to impact that. So Susan Arnold did an analysis, pre-post KCCQ scores, trying to come up with a paradigm of judging benefit from the patient's reported health status of TAVI. And bad outcomes are obviously death within 6 months, but also a very low KCCQ score, and actually not an increase, but maybe a decrease. That's not good. So when you look and plot out individual patients, and you can do that of the patients you see, you really get a new insight into what we're trying to do. So in the TVT registry, we're working on a new predictive model that's going to look at predictors of 1 year survival and of a bump in KCCQ, of people feeling better. Because that's important to know. It's important to know whether it'll go into the decisions of what people want, and these are kind of the different things that patients need to understand to make decisions. Because yes, we talk about patient selection like it's a physician-centric point, but ultimately it's obviously about people deciding what they want. And risk models have been developed, but they've been mortality-based. And Eric and I are in this committee with a bunch of surgeons, and they're open. They want to know 1 year outcomes of surgical AVR, both survivability but feeling better, because we really have to have an even playing field as this field moves forward. And so to facilitate that discussion, decision aids are being developed. And this, Megan Coyle-Wright is at Dartmouth, and she's done some amazing things of how to develop us. And this is for people who may not benefit from TAVR, they may not. How do you help them through that decision? What are my choices? Will I feel better? What are the major risks? What are the complications that may occur? And put it in language, put it in graphics form that will help people. And also these tools being available on the web means you kind of get rid of the, this person goes and sees a surgeon or whoever, and they don't get a kind of a global view, a standardization of what choices they have and the outcomes. And this is another one that's just coming online. This by the PCORI grant, down DCRI, using both STS and to the TVT registry data. It's actually almost live, allows patients to input variables, usually with their healthcare providers, to come up with relative risks from TAVR versus SAVR. So then another issue that's merging in next 5 years, and Eric and I have been talking about this, where and who should be performing this procedure. So there is clearly a dynamic. We want people to have access to it, but we want them to have access to high quality care. And those are sometimes our balancing acts. And in big countries like Canada, geographical access is important. But maybe it is worth traveling 500 miles to go to a center that's really got excellent outcomes. So looking at the determinants of site performance is something we've been working at, and one of the issues is does experience matter? Is there a learning curve? Is there a volume outcome relationship? So we looked at that in terms of in 43,000 people undergoing commercial procedures, and at that time 395, and we showed increasing experience was associated with lower in-hospital risk-adjusted outcomes involving mortality, vascular complications, bleeding, but not stroke. Now, stroke rates were low by site-reported metrics, but that's important. And then if you want to put that into some context, if I'm the first patient versus I'm the 400th patient, what is the absolute difference in outcomes in the model produced by this? Well, it's a pretty profound drop of mortality from 3.5 to 2. Bleeding complications come down almost 50%, vascular complications, and stroke comes down but was not statistically significant. And this is the way an unadjusted mortality versus procedure sequence number looks, and then you risk adjust it, and it's still coming down. And interestingly, it looks like it's coming down. The confidence levels are getting broader, but I think we all know that we continue to learn no matter how many we've done. We come up with all sorts of nuances of the procedure performance, patient selection, and post-procedure care. So learning does not end. So finally, there are many unanswered questions that previous speakers have come up. Again, the permanent pacemaker rate is not decreasing. Stroke, how do we decrease that? The frequency of leaflet thrombosis, the durability, and how will that go into things 5 years from now when you're talking with a low-risk 78-year-old about who, if they're low risk, don't have the burden of comorbid conditions, that they have a good shot at being alive at 90, 95, given the shift in things. And so that really little differences in these event rates of durability and leaflet thrombosis may spark a lot. This is a problem we've been having in that, hey, rapid discharge the next day is great, but guess what? They go home and this happens. While after surgical AVR, this happens, but they're still in the hospital. And when this happens, and they're up in the mountains of Colorado, you hope that it's just a pre-syncopal event. But I had a wonderful lady from Vail who had a great result, went home and dropped dead in the middle of the night. And I have to assume it was complete heart block. So we're actually sending everyone home who doesn't get a pacemaker with this LifeWatch technology to try to look at this issue. And we've been picking up more late heart block than we'd like to think we have. LifeWatch. So telemetries, you preset what you want to be notified. So the fellow on call gets the call at 2 a.m. Mrs. Jones just dropped beats for 15 seconds. So you really are able to act on that in a timely fashion versus something like a patch, they send it in, and you get a report, oh, they went in complete heart block, and you call them up, and oh yeah, they died. A little late.
Nothing important. Why are you calling? Nothing important.
That was going to be my question.
What?
That was going to be my question so far for you all, because we live with this with the members of the device.
Yeah.
And unpredictable, it happens, and some patients don't do very good. So has anyone about that? Yeah, has anyone about that in this? So very
So
I mean, someone maybe fell off their skis to understand that someone drive a car and crash.
So we don't know, but if you look at in-hospital and 30-day mortality rates in the TVT registry, there's about a 2% increase. And the question we want to answer is a component of that sudden cardiac death that yes, could be ventricular arrhythmias, because people obviously have other issues, but could it be heart block? And some of the traditional predictors of heart block don't seem to play out all the time. So that's a challenge. And I'm trying to say what sort of things in the next 5 years do we have to get our arms around a little better? Because the technologies, the valves are not reducing the incidence of heart block, unfortunately. So, TAVI, enormous growth, expanding indications. It is going, given this demographic surge, and no one has any idea of how to slow down the development and the rate of progression to hemodynamically severe AS. The statin trials failed miserably. Nothing is really on the horizon in terms of clinical trial to try to prevent the onset of this disease, delay it, reduce it, etc. The heterogeneity of TAVI benefit is increasingly clear, and we see that. You get people back at 1 year, and it's wonderful, and the vast majority are better, but there's some who aren't. You ask yourself, was that predictable? And if I could sit down with patient X and say, okay, based on data, at 1 year you have a 90% chance of being alive and feeling better, or a 50% chance of being alive, and if you're alive, you've got a 50% chance of still feeling crummy, the dialysis patients. But still it means 25% are alive and better. So you can see how this is going to be one of our big ethical dilemmas. It's a financial dilemma, et cetera. So these are some of the issues I think we're all grappling with the next 5 years that we have to answer. And that's why a registry like this that is so important, because it does give us at least one avenue to get long-term results. And we can get longer-term results than 1 year by linkage with the Medicare database, where we can get rehospitalization rates, mortality, stroke rates, et cetera, over a longer period of time, which I think, as the speakers again pointed out, is where we're especially at when we're talking about lower risk, not particularly younger patients who are going to be in these trials. Thanks.
Stay there. I'm sure there's some questions.
Go ahead, Sim.
John, I had a question for you about, again, this younger population that is going to be in the low-risk trial and in general. The pacemaker thing bothers me, and we'll see what the trial shows. The durability question still exists. When you have a low-risk patient who's 80, that's one thing, but a low-risk patient who's 50, where they might be bicuspid, usually they will be. I worry about the reoperation that they're going to eventually get. Whenever we've spoken to our surgeons about when they do operations on TAVI valves that have been there for a while, they always, I don't know whether it's true or not, but they seem to suggest it's a harder operation. There's more risks, especially with the self-expanding valves, maybe because in the LVOT, and damaging issues there. That's what worries me in those patients. The younger ones are going to be getting at least a one operation, or you could do a valve-in-valve, but then you get that whole, kind of tunneling problem that you can get. So what are your thoughts on those particular issues?
Well, those are key, and I think, number one, with the bicuspid valves, you have to make sure they don't have aortopathy, because now we're talking about the need for a much different kind of surgical approach than if they have isolated aortic valve disease. And I think you're already ahead of the curve in terms of thinking of, okay, when the low-risk trial results come in, aren't we going to have to approach the results in an 80-year-old differently than in those who are 55 because of those issues you lay out, and need to think about, again, individualizing decision-making in these patients and helping them make decisions? Because these decision aids are cool because they actually lay out some of the issues we should be thinking of too as clinicians, and some of them may be even more sophisticated. There's a decision aid about helping patients choose between tissue and mechanical valves, laying out the issues, laying out the data. And, I guess I believe in the Claude Bernard statements about science. If you can't reduce it to really its essential basic components, you're not very sophisticated. And that's what we have to do, I think, for patients as well as ourselves with these key fundamental issues that we all have to think through. John.
John, when you hear a fellow talk about, why he's lifetime.
Yeah.
But more importantly, they were, as he says, they were the low-hanging fruit because they were committed. They have to have a lot of surgeries in their lifetime. But the other reason is they're relatively most of the time relatively healthy patients. It's a hard procedure, much harder than the TAVR, but it's a hard, it's just more difficult, it's more time consuming. But it doesn't interfere with the surgeons. It doesn't interfere with what they have to do when they take the conduit out. It plays no role. And I also worry about the TAVR products that we're using now, that it's going to be more difficult for the surgeons. I think they're probably correct. I don't think they're just saying that. I think it's not the same operation that they would have done previously. So, we're going to have to deal with that as we go forward with the valve development and frames, et cetera.
Good point. Going back to your point about younger patients, actually the most frequent reason for younger patients in the TVT registry having TAVR is typically radiation-induced disease. And they're not going back to the OR or going period. It's a disaster, and and unfortunately, we get criticized for having too many data elements, but we don't have enough to really understand that unique group of people who survived childhood, young adult cancer, but got blasted with radiation, and it's just their aortic valve's the first to go, but they've got other radiation-induced disease that it's not pretty.
So I just say one thing, and then I'd like to move on to Jeopardy. We have a very interesting person in our program. So we have a medical psychiatrist whose specialty has been, over the last 20 years, of evaluating patients before major surgery and impact. And she's actually derived a TAVI-specific quality of life score from her interactions with, she sees everyone pre, she sees everyone post, and that's actually in a trial in Europe now to try and address these issues of, it's a 7 or 8 center trial in Europe, and including ourselves, to evaluate this in terms of how it functions versus KCCQ. She's done a lot of work in this area, and so I look forward to that. So, you want to make comments? Or?
Yeah, I just have one comment about the tsunami. You know what? One population we don't talk about so much is the preoperative population for non-aortic valve surgery, non-cardiomyopathy.